This is a request for the speakers. We will stop the recording prior to the question and answer discussion period at the end. Just a couple of housekeeping items before we get started. There are no relevant disclosures related to either the planning committee or today's speakers. I see folks are introducing themselves in the chat box, and we would ask that you continue to do that. That's our virtual sign-in. If you could put your name, discipline, or title, and your affiliation, we greatly appreciate that. That allows us to see who has joined us today. I will be monitoring the chat throughout the course of this morning's presentation, so any questions or comments that come up throughout, please put it in the chat box area, and I can help facilitate the Q&A towards the end of today's session. This Geriatric Medicine Grand Round Series does not receive any commercial funding. We are supported under the federal funding through the Health Resources and Services Administration through the Geriatric Workforce Enhancement Program. We are very appreciative to have this source of federal funding to bring this weekly ongoing Grand Round Series to all of you. Also, as a reminder, this session is accredited for continuing education credits, both continuing medical education and social work credits. In order to receive those credits, you have to complete the evaluation survey at the end of today's session. This is sent out in the email reminders, and I will post that to the chat box area towards the end of today's session. Any questions that come up about claiming the CME or social work credits, you can go to this website, and any handouts are made available by our Grand Round speakers we posted to our Finger Lakes Geriatric Education Center website. These links were also sent out in the email reminders. If you're not part of our email list, please just drop us an email or put in the chat that you'd like to be added to that list, and we will make sure that you are in our distribution list so that you get the monthly schedule of our Grand Round series. With that, I'm going to stop sharing and invite my colleagues to share their slides while I do the introduction of our three speakers today. So again, I'm absolutely delighted to welcome three of our speakers today that are going to be presenting. Holly Brown is the Associate Director of the Golisano Institute for Developmental Disability Nursing and Associate Professor at the Wegman School of Nursing at St.John Fisher College. The Golisano Institute for Developmental Disability was just funded by the Mother Cabrini Foundation for a project entitled Improving the Experience and Outcomes of Hospitalized Patients with Intellectual and Developmental Disabilities, for which Dr. Brown will serve as the project director. Dr. Brown is a psychiatric nurse practitioner specializing in the care of individuals duly diagnosed with IDD and co-occurring psychiatric conditions across the lifespan. Holly was also the principal investigator for the Special Olympics 2020 Inclusive Health Innovation Grant, which is supported by the CDC and was entitled Inclusive Health Primary Care Residency Curriculum, which focused on the development of health content for the care of people with IDD to be integrated to existing primary care nurse practitioner residency programs across the country. Dr. Shirley McMillan is the nurse specialist in the adult program at Surrey Place in Toronto, Canada. 3 years ago, the team at Surrey Place recognized the critical need for the development of a specialty clinic designed to support the needs of individuals with IDD who are aging. Care at the clinic is delivered by an interprofessional team, which includes advanced practice nursing, geriatric psychiatry, transition facilitation, and behavior analysis. Shirley holds an adjunct position in the Faculty of Nursing at the University of Toronto and is a mentor for the nursing students during their community placement. Dr. McMillan is a primary contributor as faculty and mentor for the Golisano Institute for Developmental Disabilities Nursing Fellowship Program, leading the development of the practice domain curriculum. Her nursing career has been spent in the field of intellectual and developmental disabilities in a variety of settings. Dr. McMillan has contributed to the development and co-authored the 2011 as well as the 2018 revisions of the Canadian Consensus Guidelines for Primary Care of Adults with Intellectual and Developmental Disabilities. Dr. McMillan was the first Canadian to achieve Certified Developmental Disability Nursing status through DDNA. And finally, Jasmina Sisirak is a research assistant professor and co-director of the Health Matters program in the Department of Disability and Human Development at the University of Illinois at Chicago, and a co-investigator of the CDC's Healthy Brain Initiative for people with intellectual and developmental disabilities. She is also an implementation scientist at the Golisano Institute for Developmental Disability Nursing at St.John Fisher. Her research interests consist of implementation science, nutrition, health literacy, and health promotion, curriculum development, and community implementation sciences for persons with IDD. Jasmina has co-authored 2 books entitled Health Matters, the Exercise and Nutrition Health Education Curriculum for People with Developmental Disabilities, and Health Matters for People with Developmental Disabilities, Creating a Sustainable Health Promotion Program. So again, just a tremendous group of experts that we have today, very relevant topic for all of us in geriatric medicine, and we are just absolutely thrilled to have you all join us today. On behalf of the University of Rochester, we welcome you to our Geriatric Medicine Grand Rounds. I'll turn over the podium to you now, Holly.
Thank you, Dr. Caprio. It is really a thrill for us to be talking with the group today. And so I'm going to hand it over to Jasmina to get us started. And then we'll move through our talk this morning. Go ahead, Jasmina.
Thanks, Holly. And I will let you know when to advance. Happy to be here and thank you for having me. Dr. Caprio has already kind of outlined the presentation, but consider this just a snack of resources that we'll provide for you in relation to health and wellness of people with intellectual disabilities and some things related to healthy brain and those kinds of things. I will primarily discuss health promotion initiatives, hence I'm not a clinician. And then Shirley will take over and talk about strategies for accessing developmentally sensitive care. And Holly will conclude with discussing some local resources to support education and interprofessional healthcare within your communities. Next slide, please. And you can go all the way to the next slide. Yes, thank you. We'll speed it up. As you all know, the world population faces a demographic challenge with doubling of the lifespan in the past century and a steadily increasing aging population. Demographic change is also a major issue for the people with intellectual disabilities, for whom life expectancy has also increased. This positive trend reflects improved social care and tailored healthcare, which has sought to address the health needs associated with specific disorders and severe and complex disabilities. Although this life expectancy of individuals that are aging with intellectual disabilities is increasing, it is still lower than that of the general population, particularly for those individuals with more severe intellectual and physical disabilities and certain genetic syndromes such as Down syndrome. Next slide, please. And throughout the presentation, if I use the term people with intellectual disabilities or people with disabilities, I mean people with intellectual and developmental disabilities, but just shortening it for clarity. Compared to their typical age peers, people with intellectual disabilities struggle with social determinants of health. They struggle with healthcare access and health promotive opportunities, especially as they age. Social circumstances such as income, education, employment, and support, and environmental issues such as inclusive and accessible health promoting communities. Aging individuals with intellectual disabilities are also at risk for poor health and well-being due to several biological, societal, and social factors. On average, there are 2 times the number of health concerns compared to people without intellectual disabilities. And as they grow older, they often develop secondary disabilities. Due to that, in consequence, they require more healthcare and are impacted by difficult medical decisions. Longevity may carry a substantial burden of age-related disorders such as dementia, mental health concerns, cataracts, hearing disorders, diabetes, hypertension, and osteoarthritis. Next slide, please. Due to that, they exhibit more complex underlying health conditions. They also have lower cancer screenings and preventive services, limited access to healthcare services, and poorly managed multiple chronic conditions such as high cholesterol, hypertension, cardiovascular disease, and obesity, which ultimately leads to poor health outcomes. Next slide, please. Thank you. The next couple of slides, I just wanted to talk about physical activity and nutrition. One thing to note is that adults that live in community settings have the highest cardiovascular disease risk of all adults with intellectual disabilities. And as we know, cardiovascular disease is strongly associated with health behaviors, specifically poor nutrition and lack of physical activity. And when it comes to physical activity and people with intellectual disabilities, they're not as active as the general populations. Adults with intellectual disabilities, especially as they age, continue to lead sedentary lifestyle with higher rates of overweight and obesity. 67% of the time, they're sedentary. One of the studies also found that only 9% of adults with intellectual disabilities met the minimum physical activity guidelines. And another study, and this one was international in Hong Kong, people with intellectual disabilities averaged only 2% of their daily time, which is around 10 minutes, engaging in moderate to vigorous physical activities. With nutrition, there are health or disability related issues that are concerning dental, oral, chewing and swallowing, food sensitivities, and medication use. Additionally, when you look at community supports or home supports, the food preparation knowledge is limited, and also the cost of the food and the support, and also the supports of the people with intellectual disabilities may not have enough food preparation, meal planning, and purchasing and budgeting knowledge. With nutrition, about 93% of adults with intellectual disabilities in the community have a high-fat diet. Over 60% do not consume enough fruits and vegetables. The consumption is about 2 servings of fruits and vegetables per day. What was found was that people with higher fruits and vegetable intake had lower BMI, which makes sense. And people living on their own, group home, or with family ate less fruits and vegetables than larger residences. Additionally, participants had a poorer healthy eating index score compared to the average American, which average American score was 58.2, which is categorized as needs improvement, compared to in people with intellectual disabilities, the score of 45.6, which is poor diet quality. Next slide. Next one. So some of these health problems and declines in functioning and are preventable. The health status of aging adults with intellectual disabilities can be improved by promoting healthier lifestyles with better nutrition and more physical activity. So we're looking at the key indicators of aging: good physical and mental health, healthy lifestyles and behaviors, social interaction and productivity, life satisfaction, and access to quality healthcare. The next slides are really going to focus on those, on sort of creating opportunities for good physical and mental health, healthy changes in healthy lifestyles and behaviors, and then social interaction and social supports. And I'm going to really present our Health Matters program that's done in the community settings, and talk a little bit about that through health and wellness lens. Next slide, please. So why is this important? General practice is often regarded as the basic building block of public health, and primary care is seen as a logical location for local public health activities. And I do recognize that not everyone is in general practice on the presentation today. Health promotion has been identified as one of the most important public health activities, so physicians working and nurses working in primary care settings. The major role of clinicians in health promotion is at the individual level, and it involves screening for risk factors and disease and providing early treatment advice, counseling, and referral. Also primary care can further broaden the impact by assuming roles at organizational, community, and government levels. So it's extremely important. Oftentimes you are the only people that people with intellectual disabilities sort of see, or you're the first ones that that are connected to the healthcare. Next slide. And the reason being is this, I just wanted to focus your attention to the 20%, only 20% of people with intellectual disabilities were known to and served by the state intellectual disability agencies. Therefore, that connection with the primary care is very important as an entry point to health and wellness. Next slide. So I wanted to quickly talk about the Health Matters program, its components, and reach. As I've mentioned, next slide, please. Holly, thanks. Health Matters program is a community program, and it has, the components are, the components of the program are Health Matters program certified instructor workshop webinar that teaches community-based organization staff to implement a 12-week Health Matters program in their settings where people live, work, learn, and play. Health Matters program is a physical activity, exercise, and health education program that uses the curriculum that was specifically written for and by individuals with intellectual disabilities. And the program consists of 3 1 to 2 hour sessions per week for 12 weeks, total of 36 lessons. During the pandemic, we actually were able to transfer the Health Matters program into the virtual environment, and we're able to offer it virtually to organizations. Next slide, please. A little bit about the curriculum. It is evidence-based. The lessons cover understanding attitudes towards health, exercise, and nutrition, identifying current behaviors, help individuals with disabilities develop clear exercise and nutrition goals, and then gain skills and knowledge about exercising in eating nutritious foods. And it is considered a group program, so there's that social support component. Throughout the curriculum, self-determination, choice, self-efficacy, self-advocacy, and rights and responsibilities are interwoven in the lessons. Next slide, please. And broadly, I just wanted to show you that it's been over 2 decades in the making. The first university-based clinical trial was in the late 1990s. That's where the first original Health Matters curriculum was developed. After the first 5-year study, we were able to move our work into community settings. So we moved from efficacy to effectiveness, where we developed our first train-a-trainer trial. And during that time, we were able to develop our first webinar training. So we've been training different participants in organizations virtually since 2007. We also moved into knowledge transfer and dissemination through Health Matters Community Academic Partnership Grant that we had for 3 years. During this time, we were able to develop multi-level evaluation and protocol on how to build capacity within community-based organizations to be able to run health promotion programming. And this included health matters assessment, evaluations that were validated in community-based settings. And also we wrote a protocol where we outlined different factors that would improve capacity and build capacity and improve health promotion delivery in community-based organizations. Since then, since 2013, we were able to scale up the program. Initially, in a 5-year study, we had moved the program into multiple states. We were able to disseminate it to multiple organizations within the states of Alaska, Illinois, Kentucky, Maryland, Missouri, and South Carolina. And next slide. This just gives you a little bit more since 2008, the reach that we were able to accomplish with our initiatives. So over 10,000 people with intellectual disabilities went through the program, over 2,600 certified instructors, over 200 community-based organizations in 35 states. We worked with partners in 8 countries. The program has also been translated into Swedish language and tested and implemented in Sweden. It's translated into Dutch language and implemented in the Netherlands. And at the moment, we are planning a translation into Portuguese. In 2019, the Health Matters program and all of its components were approved to meet the Administration for Community Living's criteria for evidence-based programs under Title 3D, which is the highest tier evidence-based health promotion disease prevention program, which is very exciting. And then because of this approval in 2021, ACL, Administration for Community Living, awarded Healthy Living for Maine a 3-year award of $1.2 million to expand chronic disease self-management education programs and incorporate Health Matters program into their delivery to their communities. So it's been a pretty exciting year. Next slide, please. And just during the pandemic, we, as I've mentioned, we had a very small grant that was an internal university grant, and we were able to transfer our programming into a virtual environment. And since November 2020, actually, we're onboarding 20 more organizations. Today, we're doing a welcome webinar. So we have 95 organizations across 27 states and 2 countries who have used our program, and over 200 individuals, staff members were trained with the reach of 1,700 individuals with intellectual disabilities. So next slide. It's pretty amazing. Sometimes with little money, you can accomplish a lot more than with millions of dollars. And we were really able to reach and learned a lot doing it. All right, so shifting my focus a little bit, and I wanted to just briefly talk about Healthy Brain Initiative. Next slide, please. Strong evidence with evolving research shows that people can reduce the risk of cognitive decline by making key lifestyle changes that include physical activity, social engagement, good heart health. People with intellectual disabilities have, as I've mentioned, more multiple chronic conditions at an earlier age compared to their peers. And sometimes these complex, it's also evident also with dementia. However, dementia is not a natural course for people with intellectual disabilities. And Shirley is going to talk more about this and sort of more of a clinical level. But just 6% of the 180,000 of older people with intellectual disabilities will experience a form of Alzheimer's disease and related dementias after age 60. With that, we have been, due to the sort of a high burden of disease in this population, you can go to the next slide. We were awarded a Healthy Brain Initiative grant from the CDC with the goal to support populations with a high burden of Alzheimer's disease and other dementias. The goal of our 5-year program is to provide education and training programs and resources for healthcare and public professionals and caregivers to provide person-centered care for people with intellectual disabilities and their support. The second goal is workforce development to expand and scale up Healthy Brain Initiative roadmap series. And also to develop policies and partnerships to implement public health strategies to improve brain health. Next slide, please. Our National Healthy Brain Initiative Collaborative is a partnership between the Health Matters program, which is located at the University of Illinois at Chicago. The PI of the National Brain Health Initiative is Beth Marks. Our two main partners are National Task Group on Intellectual Disabilities and Dementia Practices, and the leads there are Dr. Matt Janicki and Kathy Service, and also the HRSA Engage Illinois GWEP, Geriatric Workforce Enhancement Program, led by Dr. Valerie Gress. This project, you can stay on that slide, that's okay, you can go next, but I just wanted to mention that we're one of 3 component B projects with CDC's National Healthy Brain 5-year brain initiative. And the other 2 component B organizations are International Association for Indigenous Aging, IA Square, and Us Against Alzheimer's. And then the Alzheimer's Association is a component A. The activities, our 5-year activities are creation of an interactive Health Matters website. We also provide a webinar series, annual webinar series that are related to healthy brain and dementia. And also we are able to provide virtual coach Health Matters program to organizations for free. And we do onboarding of new organizations twice a year, every 6 months. So it's been pretty exciting to be able to provide this type of programming to the community for free. Additionally, just go to the next slide because I want to talk about it as we're going through. These slides are Illinois GWEP slides and Dr. Valerie Gress's. So I'm just passing the information and resources. They have the online accredited learning in interprofessional geriatrics modules. There's a library of 27 online training modules. The website is there. The modules are offered for free for continuing education credits to licensed professionals. And their reach has been, with a total number of modules completed, over 21,000 and almost 6,000 learner profiles. The 27 geriatric training modules touch upon managing chronic conditions, addressing psychosocial needs, engaging patients and families, integrating population health. We are working with Engage GWEP to incorporate information on people with intellectual disabilities in every one of those 27 modules. So that is a part of our partnership with Illinois GWEP through Healthy Brain Initiative. And then next slide, I just wanted to also mention that Engage Illinois has an app that is also in Spanish and Korean, and it's a dementia guide expert app. It's a free app. And thus far, they have had over 66,000 downloads, over 12 countries across the globe. And it's yet another resource that's free and available for aging population. And then lastly, I wanted to introduce the National Task Group on Intellectual Disabilities and Dementia Practices. It is a national nonprofit organization with a charter to advocate, provide technical and clinical assistance, disseminate information, aid with research, and create and provide educational and technical matter related to dementia among adults with intellectual disabilities. It's a great resource for this population. They define best practices that can be used by organizations while they deliver supports and services to people with intellectual disabilities. They have developed first instance early detection screening instrument, and you can download it on their website, and working on treatment and tracking instruments at the moment. They have a plethora of educational materials of use to families, people with intellectual disabilities, and providers of services. They also engage in discussions on public policy with respect to dementia as it affects adults with disabilities, and collaborate with federal and national organizations on matters related to dementia and people with intellectual disability care. So it's a really great resource to tuck away and to visit. Next slide. All right, this is my contact me information in our website. If you choose, you can join the email list. I'll put this link to the chat as well. We do send information on health promotion, different webinars. Oftentimes, we collaborate with different national organizations and provide webinars together. Thank you so much. And I'm sorry, I'm a little bit over time. Holly or Shirley?
Thank you, Jasmina. And I just want to echo our thrill at being part of this grand rounds today, and especially as a Canadian that's across the lake from you. So next slide, Holly, please. Yep, so we can go on. Next one. So just to let you know about Surrey Place, which is just a very small community agency, and we receive funding from our provincial partners, and we are an interdisciplinary agency that serves individuals with IDD and or autism through the lifespan. So we start from babies right to the very end, and as well as their caregivers. We have consultative family physicians, developmental pediatricians. We have psychiatrists that have special training in IDD, audiology. So when I'll talk later about being able to access audiology as part of the hearing. If there's a hearing issue, it's easy for us because we have 3 audiologists that span the 3 programs that we have. We have behavior analysts, speech language, psychology, nursing, service coordinators, and also intake coordinators. And we sit as a full interdisciplinary team because everybody has a voice, and we come together with a care plan at the end for each individual. So next slide, please. So we all know 20 to 30 years ago, individuals were moved into their community. And with them moving into the community, we have gained a great deal of research and education information. And these individuals who moved 20 years ago are aging just like all the rest of us are. And more of the agencies, especially I can speak about the Toronto area, is looking at aging in place as opposed to being sent to long-term care facilities. And the reason for that is that they're usually much younger and long-term care just isn't the appropriate setting for them. So as much, and it's so confusing for them as well to be moved from someplace they may have lived for 20 years and now go to a new place with new rules, new schedules, and it just totally messes them up. And they really have a lot of problems. And we often see the challenging behaviors come to the forefront as well. And so these elderly group homes have been created so that the individual remains within the agency and they're still able to see everybody that they know and go to the day programs. Well, not right now in COVID, but eventually when we open up again. And they're also available to have their clinical services. And and as we know that they do require clinical services that we do have to access in the community. We have some specialty, but totally not all. So it's been a challenge to find a balance of quality of life for these individuals. So next slide, Holly. So how we're talking about how aging with this population looks different from the general population. Their issues are similar, but the one biggest main difference is how early they become to show signs of aging. And this may be just due to, it could be family history, it could be the syndrome that the etiology of their IDD, especially when we look at Down syndrome. And they show the normal signs of decline, except for sometimes you forget that they're only 40 and they shouldn't be doing this, but this is totally typical for them. And their signs of aging, as I said, and I need to stress, are no different than the general population that we see. And they do require a full dementia workup if necessary. And I know it takes a lot of fast talking sometimes for us to be able to get this because they're turned down because of their date of birth. Okay, next slide. So I am part of the primary care guidelines for adults with intellectual and developmental disabilities. And I have been since the very beginning when we first met back in 2005. The first edition of the guidelines came out in 2006. We did an update in 2011. We did another update in 2018. And we're fortunate, we were very fortunate for the Canadian Family Physician Journal to allow us 2 special issues that were totally dedicated to intellectual disabilities. And this one on the screen is the one that is dedicated to aging with our population. Next slide. So what can, and probably the first rule that you'll read, if you ever read the Canadian guidelines, the first rule of thumb is rule out everything physical that could possibly be going on, then move on. Don't just automatically give them a diagnosis without looking to see if there's some other things that could be causing this. And they're certainly worthy to follow through with this. And the person needs to have this done. So, you know, I'm probably talking to the choir here, but, you know, we need to look at their thyroid. Do they have an infection of some sort, like a pneumonia or anything else that could be causing a change in their cognitive appearance? Pernicious anemia. Take a look at their drugs. We all know polypharmacy with the IDD population. So let's see if there's an interaction that's causing some of these issues. Do they have an acute illness? Are they diabetic? Is there some cardiac abnormalities? Sleep apnea is a big one with us. And I know it's a challenge to get them to use the machines, but it's certainly worthy of having an assessment. Depression. Depression often mimics dementia in our population. Constipation is a huge problem, and that's related to the drugs that are prescribed for them, their inactivity, as Jasmina spoke about. They're not active at all. It's their diet as well. So check and see. Hearing and vision loss are a big one to cover as well, because if they're not hearing, they may be responding in what appears to be something that totally isn't making sense and what's going on, and vision, as we all know, as we wear our glasses, that if you can't see, there may be problems as well. We've had people that have been diagnosed with dementia, and actually they've had strokes and a recent bereavement. And especially during COVID, we've seen this with a lot of not only their caregivers may have passed away, staff, but also peers. And that is something to look into. And they certainly are able to have bereavement counseling. It may not look like it does to the general population, but we have found ways to get around with social stories, other ways letting them express their grief and acknowledge that they're grieving, and not just assume that they don't have any awareness of someone having died. Next slide. And these are just things that that to consider that might be increasing some of their symptoms. They may have a return of past behaviors, and we often will see somebody that's known the individual for a long period of time. Oh, they used to do that when they were 10. I haven't seen that in a long time. Have a look at their medication. Stress, especially during COVID, because they've been so locked down. We feel that we're locked down. They're even more so, because their access to outside activities has been more limited than ours. And their day programs and things that they've been so used to going to for years and years and years are now gone. Is there a time confusion that they're getting up at, they're going to bed at 6 o'clock in the morning, or they think that's bedtime, or they're getting up in the middle of the night? Just look at that. And that they've lost some of their abilities to perform their basic activities of daily living. They're no longer wanting to shower. They have issues with showering, that they don't want to get dressed. They're putting things on differently than they've ever done before. Restlessness, and you need to rule out that it's not due to an antipsychotic that they're on, but they just seem to be constantly on the move, and they just can't seem to settle themselves. And I guess the big one that is very heartbreaking to any of us that have cared for someone, lack of recognition. They no longer recognize their caregivers. They don't recognize their parents, siblings, peers. And I know as a family member, my mom had dementia, and that was the most heartbreaking day for me, was when she didn't know who I was. She had no idea. So these individuals share this as well, that they've started to not be able to recognize others. And you may see an increase in fear, that they're startled easily, they're scared of the dark. They never needed to sleep with a light on, now they do. So just keep these things tucked in the back of your mind to remember while we create a holistic plan for the individual. We need to look at every aspect of their life. Next slide, Holly. So these are some of the risk factors, and I think we talk about Down syndrome because probably we have the most research about this particular syndrome, and just to let you see how early they age. And as there is as part of the guidelines, there are toolkits, and I should say everything is free. You just go on the Surrey Place website and you go to resources, and you'll come to DDPCP, and that's where all the guidelines are and all the tools. We also have health watch tables for the some of the most common syndromes in our population, and there is one for Down syndrome, and it serves as a checklist, and it goes from very young to aging, and you can go there and just check off what you should be following on the individual at what age, and what things we should be looking and making sure that we've assessed for. And so for sure, look on our website. Everything's free. Print off as much as you want, whatever you want. Next slide. So these are some of the challenging behaviors, and I think because I work mainly in mental health at Surrey Place, and has always been a passion of mine, we need to look at challenging behaviors. And all of us know as clinicians that it's a form of communication, and we need to address it as that. And it's a problem for us. It's not the problem for the individual. So we need to find a way to deal with the challenging behaviors. And that's not medication. It may be, but that's not the one and only thing. And that's where your behavior analysts come into play to give you some strategies how to deal with some of the challenging behaviors. So this is just, we all know about sundowning and shadowing, agitation, anger. They just all of a sudden react like it's the end of the world, and it's something very simple that they dropped a spoon or something. Confusion, paranoia, we talked about depression, may no longer want to eat. They'll tell you that they just ate and they haven't eaten for, you know, several hours. We talk, hoarding can be a big thing, which is an issue when they're living in a residence, because maybe their roommate doesn't want all the magazines that have been around the home all in their room, and they're hoarding other items. There's lots of items that they do. We talked about hygiene and bathing. They may all of a sudden have become incontinent, which has never been around before. Dehydration because they forget to drink, so you need to remind them or put it in front of them. A repetitive questioning, which can become annoying, and that's where behavior analysts can help as to setting limits as to how many times you can ask the same question. And this goes for anybody. We have this not just with individuals that are aging in dementia and IDD, there's others, especially autism, where they'll repetitively ask you the same question. And sometimes it can be grating, but you just need to take a deep breath and tell them you've answered it, and you give them the number of times you will answer it. Wandering is a huge problem, and we always, if they are a wanderer, are there strategies that we can put in the home to keep them from wandering, like doorbells or things that will go off when they open up the door? And we also identify them with the police, so that if they're found and have something, if possible, if they'll wear an ID bracelet or something, but a full description to the division that they're in, so that if they're found wandering, they'll know where to bring them back to. Next slide. This is one of my favorite tools that was developed by one of our psychiatrists, and it's a way to think through it's a logical step down way to think through a problem. That first you think about health, as we've talked about. Environment, is there something in the environment that's upsetting them or bothering them or has been changed? Lived experience is something that we don't always acknowledge with our individuals, and they have a lot of lived experience, and it may be abuse, but it may be loss, that they've experienced a great deal of loss. Then once you get to the P, then you can give them a psychiatric diagnosis if appropriate. But you need to go through all these steps first. And these are something I really encourage my nursing students to think about a case, and not just in an individual with an IDD. You certainly need to look at that with everybody. Next slide. We've also developed a tool for decision-making in healthcare of adults. It's hard depending on the level of their etiology, like their level of cognition, as to if they can be part of it, but we really try to make sure that they are part of it. And we also can, we also have one for advanced care planning as well. Next slide. Yeah. And it's difficult. You don't want to talk about it. Nobody wants to talk about it, but we need to talk about it, because this individual has the right to decide what their funeral or celebration of their life is going to look at, and how far they want to go. Is this, you know, they're going to refuse all treatment at one point. And then we also need to bring in the substitute decision makers to be part of it, if that the person does have a substitute decision maker, and everybody should be included. It should be a good care planning as to what to make sure all of what their desires are met at the end. Next slide. We're fortunate that we are able to do baseline psychological assessments, and we start with individuals with Down syndrome at 25 to 30 years of age, so that we have something to base it on later rather than guessing what it was like. Jasmina talked about NTG, and I have, next slide, that's my last slide. These are resources that we've used, that I have used throughout my talk. And thank you very much for your attention. This has been a pleasure to be here. So Holly.
Shirley, thank you so much. I mean, I hope you're getting the feel and that these resources will be useful to you. It's one of the beauties of the Golisano Institute that we have the opportunity to work with such esteemed colleagues and to be a clearinghouse in lots of ways for this information. So when we think about local resources in the community, I start with the Institute, even though it's not on the slide, and I'll come to it in a minute. But the first thing I want to acknowledge is I had a really robust conversation with Laura Robinson. You guys have a treasure in your treasure box of resources at URMC. Laura Robinson certainly is one of those, the emerald in the box in terms of being able to organize and sort of help think through service resources for individuals aging with IDD. One of the first things that she and I talked about was the Article 16 clinics that are available throughout the Finger Lakes area. And I had one caveat that I wanted to add to that point, is we want to make sure that our individuals that we're caring for are service eligible, that they actually have been deemed designated to have OPWDD services. And I know in EPIC, there's a new tab on the medical record that indicates whether or not the person is OPWDD connected. So that could be a good link for you as if you're working in the EPIC EMR to see if that label exists. And if it doesn't, and you suspect or you know that this person does have an intellectual or developmental disability, to wonder out loud with the caregiver and the individual whether or not seeking out OPWDD services makes sense. I would say probably almost 100% of that time, the answer is yes. And some of you should be scratching your head and saying, well, wouldn't the person already be linked to OPWDD? Not necessarily. So oftentimes folks are living at home with family members, and families have said, nope, we're going to take care of Johnny until the day we're no longer able to. And they may not be aware or in the know about the availability of OPWDD. I'm sure it's rare for many of the patients that you're working with, but I just want to call that out. At any rate, our Article 16 clinics throughout the region provide a variety of services delivered by our interprofessional colleagues, OT, PT, primary, in some instances, primary care, psychological services, as well as mental health services. And so being aware of where those are in terms of where you're located, of course, Westfall is our known Article 16 spot here in Monroe County, but there are several licensed Article 16 clinics across the community run by the ARC of Monroe I was looking this morning, Holy Childhood, the School of the Holy Childhood also has an Article 16, and they do see adults, which was surprising to me. This is not an exhaustive list, folks. I just want to orient you to the heavy hitters in our community. And of course, the ARC of Monroe is going to be the resource that many of us are going to sort of go to recognize as serving people with IDD. And so the Ballantine Day Hab services is a rich resource for our folks. Again, COVID has played havoc as Shirley indicated, with access to day services, and have contributed in a big way to mental health concerns, a sense of isolation, those sorts of things. But there are still, some of them are still open and available to folks coming in person. And in the meantime, our workforce has done an incredible job to reach out to folks, even when they were at home, to keep them connected to service and relationships. So that's important to keep in mind. Certainly, and I appreciate what Shirley and Jasmina said, you know, dementia is not the only aging concern of people with IDD, but we know that there are a variety of services that are available through the Arkham Monroe. Lifespan also has some medical coordination services available to them. And then the Alzheimer's Association can offer some education and support to people, to group homes, to folks with IDD related to dementia symptoms. So in the interest of time, I'm going to leave it there, but those are the heavy hitters for our local community. As I said, we are interested and happy at the Golisano Institute to partner with you all in terms of your work around people with IDD, to help support your teams, to think about education and support for folks that you're working with. And our mission is stated here, and our vision here as well. And so we believe, you know, nursing is as the largest workforce in healthcare, we've got to equip our folks with education, knowledge, and skills to be able to deliver the highest quality of care for this population who, you know, in all reality has been left behind a bunch based on the information, particularly that Jasmina has showed. So we want to make sure that folks, that there's health equity for all, certainly people with intellectual and developmental disabilities. So some final thoughts that I want to underscore. You all as geriatric practitioners, you all have the skills and to take care of people with IDD. And while we know that there, as Shirley pointed out, symptoms of aging onset might be earlier with people with IDD, older adults with IDD have more in common with their typically aging counterparts as it relates to health and wellness. And so this notion of sort of saying, oh, we got to refer out, I actually would encourage, with the resources that we provided today, to keep folks in-house as long as we can and try and identify specialty care with thorough assessment. Regular screening, health promotion and screening is important. Understanding a person's baseline function is going to be key, as Shirley pointed out, and the promotion of wellness is really what these folks deserve. I just wanted to also underscore, as it related to resources, that the impact of COVID has changed the landscape a bit. So maybe as a group, we could think about establishing and or updating an existing resource list for older adults with IDD. I think that could go a long way. And I'm sure Laura is saying, yes, Holly Brown, I have something for you, for us to work on. So with that, I want to thank you for the privilege of your time. We are really delighted to be able to talk with you today. Hope that this was an appetizer, as Jasmina said, and you'll invite us back to get more granular on the topic. Dr. Caprio, I'm going to hand it back to you.